rejected by him. As I told him, but he's been drafted. We can take these off now. We're at.
What's it Fauci said? Cavalry's coming, but you don't stop shooting while you wait for him.
That's right. Unless they're coming at you, don't shoot at them. Friendly fire. About here, Alex. Book open the right page. Is that your keyboard going to work?
We hope.
Okay.
We hope.
All right.
David, I'll follow your lead.
All right. Thank you.
Ready?
Mm-hmm.
Hi everyone, thanks for joining. We're going to get started now. Today we have 1 hour, and just as a reminder, one question, one follow-up. We have Dr. Brown and Dr. Williams here today, so I'll turn it over to them to get started.
Okay, well, thank you. Good afternoon. It's Thursday, and it's when we look at what's happened during this week, sort of projecting what might happen coming ahead. And it's our second Thursday since we had Dr. Brown here. So Dr. Brown is back with some more modeling and analytic updates of how Ontario's doing. So we'll be covering that shortly. So as I said, we've had a busy week, and I'll be talking about some numbers and data afterwards. So first, I'm going to hand things over to Dr. Brown to talk about how have we been doing compared to like even a couple weeks ago, and where might we be going. And I think it's very important we keep our eye on that, because it tells us how we have to really keep focusing as a province, throughout the province, in each region, each area. It's a full metaphor, sports metaphor, court press. We have to really keep our eye on this one and do well. So I'm going to hand things over to Dr. Brown, then I'll have some comments to make afterwards as far as today's numbers and how we're doing since our update on Monday with Dr. Yaffe. So over to Dr. Brown.
Great. Thank you, Dr. Williams. Before we start into the slides, I just wanted to let people know that when the slides show up on the screen, the sign language interpretation will disappear. It will be back on when we stop presenting the slides. If we could put the first slide up, please. Great. I want to just note here that this is work that comes from a number of different scientists from across the province, researchers at the University of Toronto, at the University Health Network, at Unity Health, at McMaster University, at Ontario Health, at Public Health Ontario, and at the Ministry of Health have all directly contributed material for this briefing or data sets that underlie it. We've also relied on input from colleagues from Queen's University and York University as we've been validating what's in these slides. If we could go to the, perfect, thank you. Key findings. I want to spend some time talking about the key findings before we go into the actual data itself. Cases continue to grow. Percent positivity, in contrast, appears to be flattening. This is, I guess, a small bit of good news that while we do see case growth, we also look at percent positivity against a relatively strong amount of testing in the province. And so that indicates that we may be seeing some impact from the current restrictions. It's important to emphasize, though, that the impact of the pandemic still varies widely across and within public health units. So while we often talk about a provincial level picture in these briefings, the situation within public health units and even within communities within those units can be vastly different. Long-term care mortality and overall mortality to continue to increase and may exceed 25 deaths per day within a month. Now, mortality varies day to day quite significantly, but we're able to, using forecasting, to look ahead and see what at least the average or expected amount of mortality is going to be, or deaths are going to be every day. 25 deaths may seem like a small number a day, but it is significant enough to put it among the most important causes of death in the province on a daily basis. We've talked early on particularly a lot about the reproduction number. This is the number that really identifies how many people are infected by each case. Right now it's hovering around 1. Some days it's a little bit below 1 for the province, some days it's a little bit above 1. This really reinforces this continuing sort of precarious or fragile nature of our control over the pandemic right now. A prolonged period of days just slightly above 1 will lead to significant growth in cases, whereas a prolonged period of days below 1 will actually lead to more and greater control over the pandemic. ICU occupancy will continue above 200 beds for the next month under any of our scenarios. And it could go significantly higher if public health interventions are relaxed, which would lead to an increase in the number of patients entering our intensive care units. Important though, we're now well past the threshold of 150 cases, and particularly in specific hospitals, this is leading to problems or increasing problems with access to care. Under a number of scenarios, we might actually get up above another threshold of 300 ICU beds. Importantly, the pandemic continues to impact communities very differently. For Ontarians who have access to suitable housing, for those who don't live in multi-generational households, or for those whose employment is largely outside of essential services, rates are growing slowly, or more slowly than they are in those communities where there is not as good access to suitable housing, where there is a large amount of employment or high proportion of employment in those essential services where folks cannot work from home. And I should clarify this last point. The current set of restrictions that really started on September 19th have not had as much impact on mobility and likely on contacts as the very dramatic restrictions that we had in the spring. However, a relaxation of public health interventions at this point, particularly with the widening prevention gap that we see, will likely lead to an even higher case growth. I'll turn now to the total new cases per 100,000 residents per week across public health units. This is really a 7-day sort of average that we look at, and sort of a daily average calculated over 7 days. What you see is continued growth in a number of public health units, with the highest number being Peel at about 119 or 120 cases per 100,000 population, Toronto at about 118, down, say, to Ottawa, much closer to 30 cases per 100,000, and the public health units that are not reflected on this graph being even lower than Ottawa at 29 cases per 100,000. It's important to note the variation across public health units. It's also, I think, important to note that a number of the public health units' case rates are going up over the last little while. Just before leaving this slide, I also want to note that if you look at the growth in cases in Peel, and you look at the growth in cases perhaps in Toronto, but particularly in Peel, you actually see a little bit of a softening of the slope, a little slower rate of growth here, which may reflect some early impact from the accumulation of restrictions that started in September. This slide shows the number of cases or new cases with no epidemiological link across public health units. This is an important measure, particularly when case rates are lower, and case and contact tracing, understanding where cases have come from, is a critical part of actually controlling the pandemic. At the current level of infection, it's not surprising to see a higher number of cases or new cases with no epidemiological link. But hopefully, as the total number of cases in the province go down, you will see similarly the proportion of cases with no epidemiological link also go down. But once again, as we can see in every of the sets of statistics here, substantial variation across public health units. This is another one of the key statistics that we look at, which is the percent positivity across public health units. This is the percent of tests that come back with a positive result. Again, you can see a significant degree of variation, with Peel up at almost 11% and Ottawa down much closer to 2%. Again, though, we try to look at the case growth, we look at the percent positivity, and we look to make sure that testing volumes are staying reasonably consistent. And what you can see here, both in Peel and in Toronto, is that very clear softening of the slope, that slower rate of growth, or in some cases actually reduction, likely again associated with the accumulation of restrictions in those two jurisdictions. But important to note, though, although there may be a softening overall in the province of growth here, or some flattening of growth here, you do see some regions with growing percent positivity. And finally, in terms of the variation across public health units, we're looking here at the percent of COVID test results returned within 2 days across public health units. And the variation here is very significant again. just around 40% for Brant, back within 2 days after the tests were taken, up to just over 90% in London, with test results coming back within 2 days. This is a critical measure of control of the disease when we think about the public health system capacity, the ability to identify where cases have come from, the ability to case and contact trace, the ability to get results or get tested and get results back to people is important. The longer the delay in accessing or getting results back, the harder it is to trace cases, the longer it is before people perhaps know to self-isolate. And so it's a critical measure here, and variation obviously is very important here. This is the weekly percent positivity by age group. This is a new format for the chart that we're presenting here. This is work coming out of Drs. Ashley Tweet and David Fisman at the University of Toronto. You can see here the change in the percent positivity by age group over time. On the left-hand side of the chart, that first set of spikes is the first wave of the pandemic. And I think it's important to note here the high spike in the dark blue line. That dark blue line is people over 80 years of age. And this sort of big spike like that really represents, in the first pandemic, the fact that we had a rapid growth in the community, followed by significant restrictions on movement and restrictions that reduced contacts. That brought percent positivity in other age groups down. But then we had the second pandemic, which was the pandemic really within long-term care homes. And that blue spike is that second pandemic. What you see as you look over in the right-hand side of the chart are the curves for the same percent positivity during the second wave. And you can see here both the general flattening of that percent positivity in most of the age groups, but you can also see that it's a much more distributed set of rates here, where really it's reflecting the broad community spread of the disease and the fact that it is broadly being spread in the community and distributed. This slide looks at cases and deaths in long-term care. The orange line there shows daily active cases in residents. You can see a substantially high rate of growth, a small dip, and then really kind of return to what the previous level looked like. The yellow line shows a somewhat more consistent trend upwards for staff cases, and the green line talks to the cumulative deaths. I think what's important to note right here is that we've had 496 resident deaths since August 1st, but really this has been an accelerating rate. 493 of those deaths were since September 1st, and 102 of those deaths occurred in the last 7 days. So not surprisingly, as cases rise, you will see a rise in deaths that follow by a number of weeks. This reflects the progression of the disease, and regardless of what we do now, to reduce the case rate, the mortality will continue to accumulate at pretty much the same rate. You can see here in this slide, this is work out of McMaster University here. You can see the variation, but also the overall increase in daily total mortality. There is significant variation here, and we've put the confidence intervals here for people to see. But generally, the trend is increasing up. And as we know, it will be between 25 and 30 cases a day on average, really by about the time we get to the end of the month and into January. And once again, mortality will be really the last of the indicators probably to change for us. It's really kind of the terminal outcome to COVID-19 infection, and you can see very clearly that this is lagging cases, but it will continue to lag cases if they start to come down. It'll stay up. Here, let's start to look at the projections for growth in case numbers across the province. You can see that gray line and the gray bars underneath, the growth in cases from just over 1,000 cases per day up to about 2,000 cases per day right now, almost. And then you can see various estimates of growth depending on what our current level of growth is or what the other jurisdictions whose modeling or whose behavior we're trying to understand relationship with the Ontario population would look like. I want to call a couple things out here. First, this is the modeling produced by the COVID-19 Modeling Collaborative, but it is broadly consistent with modeling that comes from Public Health Ontario, which is a shorter time frame, and modeling from McMaster University, which I believe is a slightly longer time frame. So we've got some consistency in what the estimates are telling us here in terms of the growth of the disease. If we continue on at around 0% growth, we really plateau at our current level of growth, we're going to see just about or just under 2,000 cases a day. If we have 1% growth, we're going to be up to about 22 to 2,500 cases a day. And if we see a higher rate of growth, say 3%, we'll be up to a much, much higher level at well over 4,000 cases per day. What I think is important to note here is that if we see really fast growth, like 5%, we'll be up to a significant number of cases by the first week of January, about 10,000 cases a day. And if we see the type of explosive growth in infections that we saw at during the beginning of the first wave, at say about 9% growth, we'll see 15,000 cases. It's really important to understand that at this point where the reproduction number is fluctuating around 1, small changes, even just a little bit of time above 1, can lead to substantial growth. Right now, in terms of our percent growth, we're between about 0 and 3% over the last 7 days, looking at the 7-day average. But it's above 1%, it's about 1.5% from yesterday. And if we continue at that 1.5% level, what we saw yesterday, over the next while, we will have about 2,500 cases a day in the province. Looking at the next slide, you can see here the growth in hospitalizations and ICU admissions. You can see in those orange bars the growth in hospitalizations is about 92%. This is compared to, say, 63% when we last presented it, the last 4-week growth. This 4-week period is 92%. Really important to note as well a substantial increase in COVID-19 patients in ICU at about 166% increase. But you can see here really kind of the way the disease progresses through a population here. We have a growth in cases on the previous chart. You see this lagging growth in hospitalizations, and now you see the growth in ICU use starting to catch up. And importantly, this takes us now to the projections of ICU occupancy. Last time we made this presentation, we were estimating that we'd be over 200 ICU beds at this point, and we now are. And under any of the scenarios that we look at, even a 0% growth, we do see ICU occupancy over 200 beds. There's reasons why, even with sort of 0% growth right now, we might not see substantial increases in ICU beds. That's having to try to understand how Christmas holidays and other factors integrate into this. But you can see here that if we get up to 3%, we have a substantial number of ICU beds occupied. And if we're somewhere between 0 or 1% and 3%, we're really looking at about 250 to 350 ICU beds occupied. We're already within striking distance of the roughly 280 ICU beds that were occupied at the peak of the first wave. And if we do see 3% growth, we will exceed that. I want to make a couple other comments about this to try to put the challenges in ICU care into context. The first is that this is not evenly distributed across the province. So this is not a few beds in every hospital. This is heavily concentrated in Peel and Toronto. And when ICUs become heavily affected by COVID like this, you do really start to see interruptions in service, including in necessary and emergency service. And so we're over the threshold at which we believed we'd have to start canceling and delaying elective surgery. We're now into that threshold, particularly in a number of communities where important care is being delayed. Again, if we got up to that really explosive growth that we saw in the first wave, that 9% growth or 5 to 9% growth, we would be up around 500 or more, up to 1,000 beds actually, under 9% growth by the end of the first week of January. I also want to note that it's not just ICU beds. The critical issue here is staffing. Every one of these beds requires staffing by highly, highly trained nurses and physicians, or at least a number of these beds require staffing by highly trained nurses and physicians. We're starting to see staff breakdown as you sort of look at a number of the reports coming into the hospitals. It's as much an issue of how many people we have as it is of the actual beds. And of course, the reductions in ICU capacity contribute to an access to care deficit. If you look here, and this is a chart we show every time, you can see the growth in the COVID pandemic here in terms of the total number of cases in that blue background. And you can see immediately in the first wave, that first peak, or the first tall peak there, a substantial reduction in surgery, that's the purple line, a substantial reduction in diagnostic imaging, that's the beige line, but really a reduction in almost every other type of care at the same time, including overall occupancy within hospitals. As we started to come back and learn how to manage this better, the reductions have been much smaller despite the growth in cases and the growth in ICU volumes. But we are starting to see again, first I should note that we haven't gotten back up for a significant period of time above the level of access that we had in 2019. And we're starting to see that reduction in access again here at the far right hand of the chart. All of this contributes to an access to care deficit, which has to be made up. I think it's important to note that with these types of care, particularly things like cardiac care and cancer care, these are not elective or easily delayed types of procedures, and so they're very, very important care. It's important to note as well that the access to care deficit is not just in acute care or in hospital care. It is present in primary care. It's present in access to mental health and addictions care. All of these have consequences. And if you think about the situation as with cancer, if we have a deficit in access to screening, if we have a deficit in access to diagnostic imaging, all that contributes to the outcomes that we're going to see from an overall access to care deficit with acute care as well. So it has a bit of a magnifying or a increasing effect. I want to turn now to some of the issues that we addressed in the last briefing, which is really what is happening across communities within the province in terms of rates and what is associated with those rates. We've looked at a number of factors that really lead to higher exposure to the COVID-19 virus. These are factors that are long-standing sort of structural factors and tend to hit communities with lower income. They tend to hit neighborhoods with a high degree of visible minority population the most heavily. You can see here communities with access to suitable housing in this chart. The red line is those communities, those neighborhoods with the lowest access to suitable housing. And although the definition of suitable housing is very complex, you can think about this as really having enough bedrooms for people in the house. And you can see that in those communities with low access to suitable housing, a dramatic increase right through all of the restrictions that we've seen brought forward in the province. In contrast, in those communities, the green and the blue line, you can actually see a flattening, although now this has changed and the rate of cases is growing across all of those different types of communities. If we look here, we can see the impact of multi-generational housing, and this is an important impact again to think about. When you have several generations or 3 generations in a house, obviously you have older people who are more vulnerable to the virus. But again, you can see in those communities with a high amount of multi-generational housing, that's the red line again, you can see that dramatic increase in infections. And if you look at, say, the blue line, which is those communities with the greatest access, or sorry, with the least amount of multi-generational housing, you can actually see a almost sort of flattening or slight dip as some of the restrictions come online. So big impact again in terms of how this drives spread of infection. And finally, looking here, you can see communities again and neighborhoods again divided up by the number of people, the proportion of people working in non-healthcare essential work. These are the people who need to work in grocery stores, in distribution centers, in manufacturing. They're unable to work from home. And this sort of essential work obviously keeps food on the shelves and is important to all of us. But you can see here in those communities with a high proportion of people working in that essential work, the case rates just continue to accelerate higher and higher despite the restrictions. Whereas again, in those communities where there's a high proportion of people able to work from home, that blue line, you really again see that flattening for a while with the restrictions. The importance of putting together all of these points of data is that it shows we're going to need to have a comprehensive approach to supporting these communities if we are to actually control the pandemic. It's not going to be solved with one or two tools. It requires attention to these long-standing structural factors. I should just note as well that this data is for Toronto. And again, looking here, the last of the new data we're going to show, I just want to make it clear we're really talking, when we say current restrictions, about the accumulation of restrictions that started in the middle of September and have increased since then. This gives you an idea of their impact on mobility. And mobility here we're using as a way of trying to understand how much contact there is between people. This chart looks at the percent of people's mobile devices, things like cell phones, that actually left home over each day. And you can see prior to the pandemic, over on the left-hand side of the graph, in February, for instance, most devices left home. And then you can see with the first set of restrictions that were quite significant, down here as the curve looks, most devices did not leave home. Now you can see as we sort of work through the restrictions, say on September 19th and additional ones that were added in, really a growth back to sort of not quite normal levels of mobility, but quite high levels of mobility. And although we don't have data presented here, it just came in this morning, we don't have data here that shows what the most recent set of restrictions would do. An early look at it, say in Toronto, shows that there's really very small, like a 1% change in mobility. And I should note here that this, like the preceding three slides, this is work from University of Toronto, St. Michael's Hospital, ICES, and Blue Dot, and the data both for mobility and for some of the other aspects has come from Blue Dot. So just returning to the key findings, cases continue to grow. Percent positivity does appear to be flattening. The impact of the pandemic, though, does vary widely, and there are important measures of public health capacity that show concerning variation and also some issues about overall level of success. Long-term care and overall mortality continue to increase. The reproduction number continues to sort of hover one side or the other around 1, which really tells us we're in a very sort of fragile or precarious position still. If we're able to keep that number under 1, you will see cases go down consistently, which will be important for control of the pandemic. But if it continues to sit as instead just a little bit above 1, you will see substantial growth over the next month. As predicted, ICU occupancy is over 200 beds now and increasing. It is getting close to the peak level of occupancy in the first wave. And if we see a growth in cases, for instance, if public health interventions are relaxed, you can say that number going to 350 and even higher. For Ontarians with access to suitable housing and employment outside of essential services, cases do increase at a lower rate, but these structural factors do have an important effect on exposure and really can increase exposure for Ontarians. The current set of restrictions are not reducing mobility as much as the original quite significant restrictions in the spring. If we see a relaxation of those restrictions, we would also expect to see an increase in the case rate and, not surprisingly, an increase in mobility as well. With that, I'll turn it back to you, Dr. Williams.
Okay. So thank you, Dr. Brown. And so we have much to think about as we look at that. If we look at just recently, how does that build on what Dr. Brown had commented on? You'll see that we have had an additional 5,549 cases since Monday, and we have today 1,983, which is our new single-day high. And you heard what Dr. Brown said, where we're going to be trending between 1,800 and 2,000. And so with our testing volume also going up quite extensively. So today we did just under 62,000 tests, 61,809, and that doesn't include those done at pharmacies as well. So a lot of testing getting done. And the percent positivity, while going up and down, has been moving between, I would say, about 3.3% up to just 5 and back down again. So we're seeing some change in fluctuations day to day. That's where we look at 7-day trends and see what's happening. So the average over the 7 days is 1,862, again in line with what Dr. Brown was alluding to. And that's up from last week where we were at 1,769. So there is increase, but not huge, like a 30 to 40% increase. So there is a slight decrease in the rate of increase, but not coming down. And so we're still waiting for that to happen. We're also seeing that the majority of cases, 83%, are concentrated in our red and lockdown zones. But at the same time, we're seeing a number of cases go up in the outer areas as well. So as I said before, we're concerned about that as individuals, even in some of the green and yellow zones, with lax in risk-taking behavior in congregate gatherings. All you need is introduction, and it takes off quite rapidly. And we're seeing that in a few cases where they move quickly from a yellow to an orange to red, and progressing. And we're seeing that happening in areas that had been historically for a while in very low levels in green and yellow. So we're still seeing deaths occurring, as Dr. Brown alluding, about 25 a day. And again, we had 28 today, or 35 today, reported, unfortunately, as this accrues. And we've had 73 since in the last week since we talked to you. So these losses are occurring, and as Dr. Brown alluded to, because these are cases that have already been occurring, this is a lagging trend direction. And unfortunately, some of those that are in ICUs and hospital care and that are, it's a risk, and there's a certain percent that does occur, unfortunately. Comments about that? Generally, I think from where we were a couple of weeks ago, and we heard even before 2 weeks ago with the projections from the initial ones in November, and from Health Canada saying that Ontario would be at 6,000 a day. Fortunately, we have not got there. So, in one way, we have had success in flattening down the pace of increase. But as Dr. Brown's alluded to, we haven't got that down to zero totally the increase and coming down. Our R effective, and that R factor is moving between under 1 and over 1. We'd like to get it under 1 if we could and start to show some steady coming down the other side if we could. The daily cases, as I said, they've been up to 18 to 1,900 with large volumes of tests undertaken, and it would not surprise me if we go over 2,000 in the next few days, as we're having large numbers of tests coming forward, and with some aspects of other testing methods, we'll probably get increase in that as we move forward into the closer to the Christmas season. So it's hard to comment yet on exactly the effects in Toronto and Peel with the lockdown, having had some conversations with both doctors Davila and Lowe. They feel there has been impact. Their numbers were, if we were in our original projection back even 2 to 3 weeks ago, would have been in the 700 to 800, 900 per day. They tend to be bouncing, going back and forth between 500, low 500s and upper 400s, back and forth, sometimes up to 6. So they seem to have slowed their rate of increase. Nevertheless, it hasn't gone down as much as we'd like to see. And so we're having some further discussions what we might do in there. And we'd hope to see much more progress. Now we were just over 2 weeks in to the lockdown, and to see if we've had a better impact on that. Overall, we're seeing that a number of the health units are moving up in the framework. And it's important to note in the framework, some people seem to keep asking about the framework, and they say, okay, that's how you go up, but how do things open back up again? And the advantage of the framework here is that's why we engage the public and yourselves, giving you what's happening in your area. And someone say, well, if we're in the orange zone, when would we go to yellow? You can just look at the data and the information that tells you when you would. That's an opening up. It's a closing down, going to higher and higher restrictions as the amount of cases continue to accrue in the area, as behavior is not being adhered to. As Dr. Brown alluded to, people are not staying home. They're more mobile, more active, going out and around. And one thing we're finding often with people these days, when they're doing some interviews, they'll say, have you had any significant contacts? They say, no, I don't think so. I don't know how I got to be positive. And when you ask them later on about it, they say, well, I did have some congregate gatherings with friends without masking, that kind of stuff, but they didn't have any. They didn't say they were sick at all. They found out later that they became sick shortly after, and they were at that time just incubating and were passing on the virus. And when you have positivity rates of 3, 4, 5, 10, 15%, there's a good chance there's a lot of people. If you're in a setting, someone's going to be there who will be doing that. Therefore, you have to be very stringent about those precautions because you're going to be exposed, and then you will acquire the virus. And we want to really keep this down and drive it down as you get into the Christmas season and the vacation one. And because people, while there may be some movement, we do not want a lot of movement. And there may be a single person, or there may be a student who's quarantined off-site who's going to come home and maintain that quarantine function and enter back in the family for that period. We have to be very careful about that. One, that they're not bringing anything back, and of course they're not going to take anything back to the university setting when they go back again, or college or dormitory, because they may be going from different zones. And we want people limiting their movement between the zones, And I know there's that Christmas song, "There's no place like home" for the holidays. We mean home and stay home and in your household. That's what we're asking for. And as you saw with Dr. Brown's data, we're nowhere near what we did at the first wave when we drove that down. That limited mobility was really terrific, and Ontario led the way. We're not doing that right now. We've come down leveled, but we have not come down. And I can tell you when I'm required to drive on the highways and that, the traffic load is very similar to like it is during a non-COVID season. And so there is a lot of people on the move. We have to get that down and limit that somehow. So, and the other factor is that when we are talking about these things of lockdown, that as compared to the first wave, you have to remember that we were not in lockdown then. You have to remember schools were closed. Long-term care had no visitors. Hospitals had closed down all except critical surgeries. And ED loads and hospital loads were down considerably. We now have schools still open. And we have maintained strong guards around that, picking up more and more cases all the time, especially from our high zones, of students showing up, both elementary and secondary, positive, but our tracking back and our testing tends to indicate it's very much from the family. And so people are being put at risk and exposed. And at the same time as Dr. Brown was aware, the concern is in our hospital systems. Our hospitals open and trying to function as fully as they can to catch up on the backlog, to deal with the urgent issues that are there. But that means then these beds coming in, they start to push back on that. So by not taking these precautions, you put the healthcare system at risk in your areas, and they have to then curtail, including we're having more outbreaks in our hospitals. And that has even more impact on the staffing situation. So we're in a very precarious stage here, and we have to really watch this carefully if we are not going to have to close some things further. So we're bending the curve a bit. As the data shows, we are slowing the rate of increase, but we have to do better than that. We have to flatten it. We have to start some downward trend. We have to get that R effective less than 1, not just in Toronto and Peel and in the zones around the GTA, in the outer ones too. And some of our smaller ones are hitting that right now, and they don't need many cases to put them into an outbreak situation. So those are the comments we have to make, and we're going to have time for questions now from the media and to try and talk about where we're at and where we're going and what we need to really focus on locally as a system, as a province, and as citizens of Ontario to bring this under control while we wait for the vaccine to come. And it will come, but it's going to take time in working it through before we have it as a major factor. We still have January, February, and March ahead of us, and we got to get that down. So that's our message there, and over to the media for questions. Thank you.
We'll go to the phone lines. Just a reminder, 1 question, 1 follow-up. Over to the first question, please.
As a reminder, please press star 1 if you have any questions. First question is from Ashley Legasic at News Talk 1010. Please go ahead.
Hi, doctors. Thanks very much for taking my questions. This is for both Dr. Williams and Dr. Brown. It's clear that most cases in Toronto have no known epilink. So what exactly is the reason for this? Is it a discrepancy with contact tracing? Is it people having too many contacts? What exactly is contributing to this?
Well, thank you for the question. And when we are asking our people who are doing the frontline work of case contact management, they're finding more and more people come saying, I don't know, I don't think I had any contacts. And either they were not remembering them, they thought they were insignificant just because, well, they seemed fine. Yes, we chatted for having a coffee for an hour in a place. We didn't wear a mask, we didn't take precautions, but I don't think they had COVID. Or some may say, well, I really don't want to tell you, or because that's putting other people at risk, and we can't get on top of that. And we find some people say, well, I was at this public setting, I grabbed a group here, and that morning, this afternoon, and evening, I don't know, maybe 40, 50, 60, or 100 people. I can't recall who they were. So we're getting this very much casual approach around restraining oneself of moving out around the house, contacts without proper masking and distancing in a number of multiple settings, almost like validating why I thought it was okay. And yet we're saying with the positivity, especially in the areas of the orange, red, and lockdown, with the positivities moving well above 5 to 10%, that means in your small group of 10, there's a good 80% chance one person's there who is incubating and spreading, going up to 100%. So you cannot take your eye off the ball on that. You have to keep focused. We're finding that when it gets over a certain number, there seems to be a certain group in the population that have sort of, in a way, abandoned that kind of precautionary approach. We can't have that because that backs up to tracking it back. It moves into transmitting to family members. It moves into transmitting to kids going to school. It moves into transmitting people going to work in long-term care homes and staff going to work in hospitals, and the whole thing just starts backing up. So you may think in a certain age group it's not a big deal. It is a big deal. And so we need to get that focus back. You should be able to say, I think the significant contacts I had in the last 5 to 7 days are these. You should be able to know. And it surprised me that they don't. I don't know if Dr. Brown has anything to add to that, but maybe.
I'll just say that when you do see case growth over a certain level, it becomes increasingly challenging to trace contacts. And as well, when you see that a lot of this is associated with where people work, it becomes challenging sometimes to figure out what has happened and where that has occurred. We are looking more closely into the information as well, and we may have a little bit more insight the next time that we brief.
After analyzing this information, and Dr. Williams, this can be for you as well, but after analyzing this information, after presenting this today, if you were to advise the province on next steps to get a control of what's going on here, would it be more restrictions, fewer restrictions, different restrictions? What precisely would you recommend that you think would work?
So, as I said, that as we're going for the data, we will be recommending that health units are moving up in the framework. Some greens are going to yellow, yellows to etc. So we'll be bringing those recommendations forward to the cabinet for decision, and we'll be making some announcements on Friday on what those are. We're still getting some more data in. We got some final analysis, but one way to do that, as I said before, the framework, as you move people up, more and more restrictions are put on wider groups and areas in that to seek to keep that number down, to limit the interactions, and to try and flatten the curve in that regard. And we're having discussions also with those in the lockdown, doctors Lowe and DeVille, to say what else could or should we do to not only just keep it level, but to start to bring it down. And we're 2 weeks in, we may see some more effects in there. But the real task gets back, we hear it again and again, it's people in their personal, social, and home type exposure risks that are taking place. And that's where it gets back to every citizen doing what they need to do, doing it again, and doing it consistently, and all the precautions we put in. So we're going to continue to address that, look at ideas, and as you're seeing, some medical officers, health and areas, besides the restrictions in the framework, have put in even further orders as they see certain areas that they want to put more restrictions in, and we of course applaud them for doing that, as they know where their risk factors are being greatly exacerbated within their respective jurisdictions.
Next question.
Next question comes from Rob Hindi at AM 800. Please go ahead.
Dr. Williams, for Windsor, Essex County, our numbers keep on increasing. Right now we're in the red zone. Can we expect an announcement tomorrow that we will be heading to a lockdown?
Well, yeah, thank you for the question. We've been watching the numbers there, and they have been going up quite assertively over the last couple of weeks. We want to look at some new data and numbers. I've had some discussions with Dr. Ahmed and his concerns there, and what steps he is taking at this time to seek to try and curtail that spread, and what else we can do to assist. We're giving him extra staffing to help out in the case contact management, and any resources we can do to assist him to see if he can slow the rise that he's seen. Because if you look at some of the charts from Dr. Brown, just a couple of weeks ago, they were quite down low, and they moved up almost exponentially in the last 2 weeks. So we have some challenges to deal with there. So we're going to be watching and monitoring and working cooperatively with Dr. Ahmed, as well as with the municipal leaders within the Windsor-Essex region.
Follow-up?
Dr. Ahmed just released within the last hour a Section 22 order ordering schools to shut down next week, elementary and secondary schools to shut down for the week. Just want to get your thoughts on that order, and do you expect other health units to issue similar orders?
So I did have some discussions with Dr. Ahmed, and what was unique in his area is how fast the amount of cases are going up. Some places find that they have certain schools in areas that have a cohort, a classroom that's closed, and in the province-wide, the number of school closures is amazingly low, even for Toronto. Some have been closed because of some cases, but also mostly due to administration issues that the Board of Education feels it's better to go over to a virtual type setting. When I was talking to Dr. Ahmed, instead of seeing a cohort 1 week and another cohort another week, he's sometimes seen 3 to 4 new cohorts every day ramping up. And so with that in mind, and with his unique population issues there, he had said he feels it's strongly necessary to ask parents to have children switch to virtual in the next week before the Christmas break, to see if he can use that to get on top of limiting and bring that down. Other health units have not seen that in there, even in the lockdown zones of Toronto and Peel. Still the stringent monitoring, while they pick up a lot of cases coming in, they're not getting a lot of transmission within the schools. But there's a lot of kids, more and more children coming positive. When they track that back with some testing, it tends to be linked to family and family positivities and contacts in that area there. So others have not seen that same thing. I will mention that Dr. Ahmed is keeping the child care centers open. He's just asking the students to switch from in-class to virtual for the final week before the Christmas break.
Next question.
Next question comes from Lorenda Redicop at CBC. Please go ahead.
Hi there. Looking at those 4 different modeling projections, there's such a huge difference we're seeing in terms of what could come in a month. What will make a difference in terms of where we're at?
You want to start?
Sure. So the fundamental thing that makes the difference in where we're at is the rate at which the virus spreads. And this is why we keep on talking about this fragile or precarious situation. If people are able to get tested quickly, if they're able to self-isolate, if we can support communities as they try to ensure that folks actually can isolate and can get tested, you'll actually see that come down. That's just sort of the iron law here. Reduce the contacts with people who are infected, you reduce the spread of the disease, and that number will come down substantially. But right now, it's just fluctuating up and down, just on either side of one, and it's really a precarious position. A few bad outbreaks, a few of the what we call super spreader events, or a decline in adherence, you could see it kind of take off quite quickly. And I think even more worrisomely, this can happen very differently in different communities. So if you see this happen in a small community, you could see the picture in that public health unit change very rapidly, and within a week be in a very dangerous area.
Follow-up?
For Dr. Williams, are you guys hearing me okay?
Yes, we can. They'll move the camera in a moment.
Okay, great. So for you, Dr. Williams, in terms of your recommendations for Christmas for people, do you plan on recommending things such as that people don't fly?
We are certainly at this time, our concern here in the province is that we're going to we like households, keeping the group numbers down. Even those in the yellow zones, I think that's a good precaution to take at this time, especially those in the orange, red, and lockdown zones. It's very critical to minimize the contacts outside of your household. Don't really go out too much unless you need to. Keep that for essential. Still giving support, of course, for people who are locked in, elderly people who need some support and help with proper precautions, and that can be done. And so we're asking for that. Everybody's doing the infection prevention control thing really carefully over this time. Still looking at how you maximize those virtual holiday celebrations, whether it's Hanukkah or Christmas and into New Year's. I think there's many creative ways I've seen already. I've seen a lot of people doing their different ways of getting all their purchasing and things done. So we're asking people to prepare for much more of a COVID Christmas and New Year's, so that we can get ready for our inroad of vaccinations in the new year. That's the good news story coming down, but it's early days, and so that we can look forward to a more normal type activity next year. But I think this year is going to be very much limitation. That means the travel motion around in the province should be minimalized unless it's essential in that. We don't have a lot of people going out in high zones to other low zones. It's like back in the summer when we did the cottage country issue. If you do go, bring all your supplies with you and don't go into the areas and utilize those services, because while they didn't have a lot of services back then, they have any less now because there's not a lot of activity, especially in their health services, so they have limited capacity to deal with issues that you might run across. As far as interprovincial travel, I mean, international I have great concerns over in general, and there's a lot of concerns there, and that's why we still have the federal quarantine laws. They're still in place, requiring the required quarantine rules, and especially people going to very high-risk areas. I think you really need to weigh that out and consider not going, strongly not going, because you're going into high zones of transmission, and without the resources, both family and otherwise, to deal with illness if it did occur. Across the country, you've heard other provinces asking not people to travel from one province to another. Different CMOHs have done that in there. We haven't put any bubble on, like having Atlanta not coming to Ontario in that, just because we are still saying in general limit your travel in there and keep it to essential. And if you wear, you have to do your proper quarantining beforehand, all the precautions while you were doing that traveling, whether it's in driving or otherwise moving through, because you're going to be going into places to get gas and things. So I prefer you didn't. In that, we haven't put any strict rules about that, except we would not want you going from high zones to low zones unless it's essential. And we understand there is need for essential travel during this time.
Next question.
Next question comes from Sajia Liu at CTV News Windsor. Please go ahead.
Good afternoon. Thanks for taking my question. I just wanted to ask more about the closure of schools in Windsor-Essex. How effective do you think this measure will be when it comes to flattening the curve in our region, given our unique cases here?
So that's a good question. I think one thing we're trying to deal with that, while we do see some children, they're bringing more into the schools, so we certainly don't want to go into a case where we're seeing widespread transmission within schools. We have seen that in other jurisdictions, and I know at Windsor you did experience that, where there was inflow into the school. There was active transmission within a school, in a couple of schools, and so Dr. Ahmed has seen that, and there's a concern that he really can't have that happen again, because that did result in a lot of cases, and of course that flowed back out into the community, and even further out into other community members in there, even out into the more farm type areas that is concerned. So it's not that he hasn't seen that. He has seen that, and he doesn't want that to add to his challenges and issues right there. So I think it will assist in it, just because of the unique challenges that he finds himself with, and the history of having seen that happen just a couple of weeks ago in your jurisdiction. So what we want to do everything we can to stop this rapid rise in cases in the Windsor-Essex area.
Follow-up?
No follow-up. Thank you.
Next question comes from Christina Tanalia at CP24. Please go ahead.
Hi there. Thank you so much for taking my question. Dr. Williams, I know you and your colleagues have commented on this a bit, but I wanted to ask you about your point that the current lockdown has not had as much of an impact on mobility as the lockdown in March. Is that because in the spring, the entire province was locked down, so there was nowhere for anyone to go, as opposed to what we're seeing now, a regional approach? Is it because people in the regional lockdowns are going to other areas to go shopping, let's say? Or is it because kids are in school as of September, well, until right now? Or is it all three? What does your data show in that regard?
Well, I think, you look at the data that Dr. Brown has shown, talking with Drs. Lowe and Davila. The differences, remember, in the first wave, we had closed down pretty well all workplaces except for some key ones such as construction and others. We had basically people not going out except for essential. Most retails were totally closed down. Restaurants are totally closed down. Schools were closed down. And the limitation of going out to a number of things was really minimal at that time. And so this time we've attempted, based on the data and information we've received, we're monitoring the schools to say, are the schools the cause of this? We see more of the schools are like the barometer measuring the level of community spread. So they're coming in, and we're fending that off at the doors, if you may, and the classrooms, picking up more and more children from the high-risk zones, and some of the faculty and administration coming in and find them, identifying them, and quarantine them and send them back for testing. And we're seeing how the new lower bar on that Toronto and Peel set in to see if that will assist in the matter. But we're not seeing a lot of transmission in the schools, fortunately. That means our system of keeping that protected is working. But it's like having more higher waves hitting the wall and coming in, and you got to say, how well is that going to be? So we need that community rate down to keep our schools open, because the data and information we receive from our experts, like child psychologists and education leads, et cetera, is the impact of that prolonged absence of school attendance is a measure we have to deal with, and we want to make sure we do not compromise that. The same as with long-term care. We felt the necessity this time to still allow essential visitors to go in. Why? Because there was that effect of not having that contact, and we want to do that. We want to maintain that. We haven't blocked them off totally. We're putting in more and more stringent measures of control. People have to log in. People have to have the proof of testing. And we may do more frequent testing. So it's a number of things we're doing. We're trying to put the walls around those groups to block that. That doesn't seem to be the problem. As Dr. Brown has shown you, the mobility is the big difference. There's more and more people out and around doing more and more and congregating more and more. And it seems to be with COVID fatigue and other aspects there, people either become complacent, complicit, and different things than that, and going that way. And that's where our challenge is. And with our public health officials saying that's where we're seeing it. We're seeing people in their personal behavior has slid, and they're not being as stringent and careful in their activities and personal activities. And what can we do to get that back down again? And on that curve he showed with the mobility, we got to drop that considerably, down about 30-40%. And because we're way up there, and I can tell you, as I said, the action around on the streets and highways is that it looks like it is like normal time in there. So we really got to make some impact on that. The virtual methods are there. We can do that. But we're going to have to tighten down. But I don't think the schools have been the factor. They are more the recipient of it. And I don't think the long-term cares are the cause of that. They're more the recipient, and the canary in the minefield is it's detecting the cases coming in the door. And we're putting those people at risk. So we're going to try to look at other methods, how to get the people to grasp and saying, okay, we've got to get back and be strict and disciplined and do this. Because it's spread from person to person. It's not spread from off the ground It's that distancing. It's those messages. It's fairly simple. But it seems these simple things are hard for people to do day in and day out. And especially now coming up to Christmas, New Year's, we're very worried in Hanukkah that people may say, well, whatever. No, it's not whatever. You got to do whatever you can to stop it. And we need that action. I don't know if Dr. Brown has any further comments on that, but the data, I think, is from the modeling is very compelling. And it's there.
Yeah. The only thing I'd add to Dr. Williams' point is that there is more mobility, and it has not gone down in the same way with the accumulating restrictions. It's really important, though, that we think about test, we think about trace, we think about isolate, but we also think about support. In all of these are people who sometimes would find it difficult to self-isolate, would find it difficult to take care of all the things in their lives that need to be taken care of, and so the support aspect of it is critical as well.
Follow-up?
Okay, thank you so much. Oh, 1 second, I'm hearing my echo. Thank you, Dr. Williams, for mentioning COVID fatigue. That was what I was getting at. I wanted to ask you both quickly about the rollout of the vaccine based on this modeling. I know, of course, General Hillier is leading that, and he's actually going to be speaking to reporters in a few moments. But what recommendations, if any, have you provided the Premier, his cabinet, the province, the task force on the vaccine rollout based on this latest modeling?
So I think you raise a very good point. And one thing about the COVID fatigue, if people say, I don't see anything on the horizon, and now the vaccine coming in, we see the light at the end of the tunnel. That means you say, okay, I guess we're going to be in this for the next 2 or 3 years. So we see this there. So that sometimes lifts the fatigue. People say, okay, the finish line is getting close. Let's stay the task. So I think that's an important point. My recommendations, I mean, I'm on the task force as an ex officio, and there's people at the work tables. Our staff are there who have been doing the annual influenza campaign. We just did our most successful one, moving out over 5 million doses in the province of Ontario, working with our partners, the public health units, with the pharmacy, with the primary care doctors, with the pediatricians. And that's no easy task in a matter of 2 months doing 5 million people. That's one advantage Ontario has, is every year we do that. We have those machines in place to do that. What we need is a lot of vaccine and get those approved and coming out. So we're getting ramped up, ready to go. The aspect, too, is it's hard to immunize a whole bunch of people who are sick with COVID at the same time. We would rather have it with people being at low levels and immunize them so they don't get COVID. So we want to make sure we drive that forward, and the guidelines we're giving are consistent with our federal counterparts. We're at the table at our Special Advisory Committee and with the National Advisory Committee on Immunization, who we should do first, second, third, and as the vaccine comes in. So General Hillier is taking that into account. I'm sure he'll be talking about that with you shortly as he continues to ratify this whole program that's pretty consistent across Canada in that way.
Okay, thanks everyone.